So welcome to another series of our A to Z pharmacotherapy. We are currently at D. So our A to Z pharmacotherapy series now will be on Dapagliflozin et al., the growing therapeutic spectrum of SGLT2. So to kick off the session, I'll just do an introduction to the panelists, the speakers, as well as the moderator for this session. So my name is Claire, and I'm a senior pharmacist at Seng Hospital currently. Co-moderating with me will be Prof Doreen Tan, who is a cardiology specialist pharmacist at the Department of Pharmacy in the National University of Singapore. So moving on, for our speaker for today, who will be kicking off this series, will be Prof Felipe Martinez. He's the director at the Instituto DAMIC Foundation at Argentina. And we are also delighted to have two panelists with us to answer some of the pressing questions and cases that we'll be going through. The first one will be Prof Tiongco, who is an associate professor at the Philippine General Hospital in Philippines. And our next panelist will be Prof Cheung, who is a professor at the Department of Medicine of Queen Mary Hospital at Pokfulam. So with that, just a few disclaimers and housekeeping before we start off the session. The content of this webinar is copyrighted by the ISCP. The views and opinions expressed are those of the faculty members and do not necessarily represent those of the ISCP. So this webinar is live streamed via ISCP, APSC Facebook and YouTube pages. So CME points will also be submitted for those of you who are connected throughout the whole duration, and you'll receive your certificate of attendance upon completing a survey sent via email post-webinar. So if you do have any questions throughout our entire session, do feel free to click the Q&A button at the bottom, and we will hope that we can answer your questions in this short 1 hour duration. So let's get started with part D of pharmacotherapy series. And with that, I introduce our speaker, Prof Felipe Martinez, who will be first giving us an overview of the topic. Prof Felipe Martinez, please.
Hello, everybody. I'm Dr. Felipe Martinez from Argentina. And I am going to share with you my presentation, as you may see in the screen, about Dapagliflozin et al., the growing therapeutic spectrum of SGLT2 inhibitors. This is my disclosure, and the first slide will show you what most of the colleagues think is a surprising start with this group of drugs. After many important trials in diabetic patients, two of them, the CANVAS with canagliflozin and EMPA-REG with empagliflozin, showed almost the same benefit in cardiovascular outcome in diabetic populations, and mainly a clear lower incidence of heart failure outcomes related. Second, when it came the consolidation and expansion of this previous surprising start. After a couple of years of research, we completed, presented and published DAPA-HF, Dapagliflozin versus placebo, on top of regular treatment in patients with and without diabetes. And the result showed a highly significant benefit of the group of patients receiving Dapagliflozin. And it was almost very interesting to demonstrate that this benefit was almost the same in patients with and without diabetes. It was demonstrated for the first time for this group of drugs. Even it was very interesting, a sub-study that we published a couple of months later demonstrated that the benefit of Dapagliflozin was even greater in patients older than 65 years old. As you know, this is the population where the incidence of heart failure is higher compared with the rest of the age groups. 1 year later, another trial, Emperor reduced with empagliflozin, showed almost the same in general population. And this year, for the first time, a very interesting group of 2 trials, the Soloist and Scored with sotagliflozin, demonstrated that the lower incidence of cardiovascular outcomes was independently of the range of ejection fraction. And it was shown that in diabetic patients, and this is important to outline, even in the group of patients with ejection fraction with more than 40%, the benefit was also clear. And finally, in the European Congress of Cardiology this year was presented Emperor preserved with empagliflozin in patients with ejection fraction more than 40%, and it was demonstrated a clear positive result in the patients with and without diabetes with ejection fraction with more than 40%. The primary endpoint was the combination of total mortality and heart failure hospitalization, and this one was the main driver of this positive result. Last year, with Giuseppe Rossano and David Quick, we prepared an analysis of the major trials that were published, or even some of them are ongoing, like the liver, with SGLT2 inhibitors in patients with and without diabetes, in patients with ejection fraction in different ranges. And we demonstrated that there were randomized almost 30,000 patients in this group of trials. It means that the results were consistent, and we must accept that this new group of drug is confirming the initial results. Even more, after that, just a few days ago, it was presented in the annual meeting of the American Heart Association, the Chief Heart Failure Trial, which is very interesting because it was fully remote organized, and it showed that canagliflozin improved heart failure symptoms in patients with and without diabetes. As you may see, it was a middle scale trial, but it was interesting because it was 100% virtual, and it was including patients with ejection fraction with different ranges. The third point I wish to explain is how do they work? How we can explain that this new group of drugs are producing so many benefits in cardiovascular patients, in cardiometabolic patients. I would say that there are two groups of mechanisms that are consistently being demonstrated that are effective, that they produce positive effects. The first one is the diuretic, natriuretic glucosuric effects. That was the initial way that this drug was presented or introduced in the market as hypoglycemic drug, because they produce glucosuria through the blockade of the receptor that absorb glucose in the renal tubes. But there are many implications, and we are going to see later some new interpretations of this interesting mechanism. One effect with hemodynamic impact in heart failure patients is that this group of drugs produce a differential regulation of the interstitial and intravascular compartment compared with loop diuretics, as you may see in the slide. But let me move now to the other very interesting, attractive, and provocative group of mechanisms producing protection and improvement of cardiorenal function. I recommend this editorial written by Milton Packer about the interaction or the different group of mechanisms that may produce benefit in the interaction of diabetes with heart failure, but they also explain some of the new interpretation about the mechanisms of this group of drugs. Milton said or talked about 3 groups of mechanisms. The first one is the upregulation of SGLT2i and downstream effectors. This SGLT2i is one enzyme of the group of factors that produce inhibition of the oxidative stress and protection of the mitochondrial function. Therefore, if we stimulate this group of enzymes, obviously we are trying to make an antioxidative mechanism and protecting the mitochondrial function. The second group of mechanisms is the interference with the sodium hydrogen exchangers that are located in the kidney and in the cardiovascular system. The NHE1 are in the cardiovascular system, and through different mechanisms, when they are hyperactivated, that is the case of heart failure, diabetes, and other cardiometabolic disorders, may produce progression to heart failure. The other exchanger, the number 3, are located in kidney and also through different mechanisms may produce progression of diabetes. It is important that the neurohormones of the renin-angiotensin system that are also activated in these pathologies may interact with the hyperactivation of the sodium hydrogen exchangers. And it is also interesting to understand how and why the new group of the so-called hypoglycemic drugs may interact in these exchangers. The GLP-1 agonists and the DP4 inhibitors may produce inhibition mainly of the exchanger located in the kidney, producing some benefit in the pathogenesis of the diabetic patients. But the SGLT2 inhibitors produce inhibition of both exchanger, and therefore they produce a more important benefit in the cardiovascular and metabolic disorders in patients with diabetes and heart failure. Obviously, the inhibition of the angiotensin, the renin-angiotensin system may contribute to the inhibition of the sodium hydrogen exchanger and may produce additional benefit, and therefore they are proposed to be used together, as some of the major trials have demonstrated the benefit of this strategy. The third group of mechanisms proposed by Milton Packer is very interesting and is in the top of the publication in this moment. It's the reduced mass and biological activity of the famous epicardial adipose tissue. This may produce anti-inflammatory mechanisms and also to inhibit myocardial and renal fibrosis. Let me explain a little more about this interesting mechanism of action, and I take this very recent publication that calls the epicardial fat as the centerpiece for myocardial protection. Why? In this very difficult and heavy slide, I will try to explain in a more simple way. The glucosuric effect produces a lower insulin and a higher glucagon levels in plasma, which goes to a lipolysis, obviously lower epicardial fat, and this may produce adipokinesis, lower inflammation, lower arterial stiffness. In the other side, the natriuretic effect may produce, obviously, a lower plasma volume and a lower cardiac filling pressure will conduct to an obviously a myocardial decongestion and a negative sodium balance. But it is also interesting that this mechanism, in particular the glucosuric effect, the initial one that was part of the presentation in the market, is related to another very attractive mechanism of action, as this very recent publication shows. The SGLT2 inhibition mediates protection from diabetic kidney disease by promoting ketone body-induced the inhibition of the mammalian target of rapamycin that is very common among the oncology world. In the slide, you may see that the diabetes produces the deterioration, fibrosis, apoptosis, etc., and the stimulation of the ketone bodies produced by the gliflozins try to inhibit that deterioration produced by the metabolic effect of the diabetes. Even more, this group of drugs produce simultaneously some changes in the alpha and beta cell in pancreas, which try to increase the glucagon and the lipolysis, as we said, with the glucosuric effect. And in the other side, in the right part of the slide, you may see that this mechanism, the glucosuric and the activation in pancreas or the depression of pancreatic cells, may conduct not only to reabsorption or lower the reabsorption of sodium, but also to increase the ketone body reabsorption, producing the benefit that we have seen in the previous slide. This is a very interesting interaction, metabolic and enzymatic hormonal interaction that is inhibited or stimulated according to each step by the SGLT2 inhibition. There is consistent evidence that most of these mechanisms of action are focusing in the inhibition of oxidation, inflammation, and fibrosis. And there is a clear and well-known interaction between these main actors in the deterioration of cardiorenal function. The gliflozins are producing some demonstration that may inhibit these different mechanisms and obviously avoiding the tissue remodeling at the cardiorenal level. And most of the pathways used by this drug are inhibition or stimulation by enzymatic pathway, paracrine regulators, immune modulation. And this is very important because a very recent state-of-the-art review published a few days ago in JACC, coordinated by the candidate to the Nobel Prize, Victor Sau, and with the participation of some of the top 10 basic researchers in the world, are concluding that there are now well-known mechanisms at the myocardial cell and cell products to promote cardiac repair. Among them is the paracrine regulators and the immune modulation, where apparently the gliflozins may participate. And there are already published some articles showing the potential anti-inflammatory mechanism of this group of drugs, and also that is the case of dapagliflozin, the regression of ventricular hypertrophy in diabetic patients. There is a growing impact of these findings in the practical management of heart failure. The first and very interesting one is the publication proposed for a group of experts trying to make some changes in the conventional sequence or the management of drugs for the treatment of chronic heart failure to a more expedited one or accelerated one. The last one is really very interesting because they propose to use the different groups of drugs in only 4 weeks. And I wish to to emphasize that SGLT2 inhibitors are in the first line of the different proposed sequence that we are facing. And another demonstration is that the last guidelines in heart failure published by the European Society of Cardiology put dapagliflozin and empagliflozin as a 1A recommendation, including the other well-known drugs. And finally, what is beyond heart failure with this group of drugs? First, there are many mechanisms proposed to be beneficial in hypertension. There are small-scale trials demonstrated that this group of drugs could be used in the near future to treat some patients with hypertension. But even more attractive is what we published this year, the DAR-19 trial, dapagliflozin in patients hospitalized with COVID-19, that showed a clear benefit, non-significant but very consistent, preventing respiratory, cardiac, and kidney decompensation. It is the first time to be shown, and the implications of these results are stimulating some new trials in other inflammatory disorders. In conclusion, in several large trials, SGLT2 inhibitors have prevented heart failure and lowered cardiovascular outcomes in patients with and without diabetes. Second, recent guidelines have recommended this group of drugs as first-line drugs for heart failure with reduced ejection fraction. Third, there is consistent evidence that some new mechanisms of action can produce clear benefit, not only in all types of heart failure, but also in other metabolic and inflammatory disorders. And finally, many recent publications indicate that the therapeutic spectrum of SGLT2 inhibitor is clearly growing. With these beautiful pictures of the wonderful Singapore, many thanks.
Thank you, Prof. Felipe Martinez. The organizers, I can't seem to start my video. I think you have blocked it. I think the rest of us can't start our videos. Yeah, thanks. All right, thank you, Prof. Martinez. I was just joking that we may have to put SGLT2 inhibitors into our drinking water. What do you think? Yeah, let's first address some of the questions that we had from some of the audience first before we go on to our cases. And we've got two very interesting cases that Claire will lead us through in a bit. So thank you, Prof. Martinez, for the interesting talk. And we all know that even with DAR-19, that SGLT2 inhibitors can potentially be beneficial in COVID-19 patients as well. That's really, really impressive. So let's talk about the question that's posed by our colleague, Mr. Adel Hamid, maybe Dr. Adel Hamid, I apologize. And his question was on the effect of SGLT2 inhibitors on serum uric acid as well as magnesium levels. I believe SGLT2 inhibitors may increase uric acid levels, but I think I'll let the Professor Martinez address this question. Professor Martinez?
Yes, I would say that these are some of the multiple new mechanisms of action, positive or negative, that are being investigating with this new type of drugs. In the case of uric acid, I think that there's not enough evidence yet to have a clear answer. So probably the interpretation that this new or not so new group of drugs are metabolic drugs acting, as I showed, through enzymatic pathways, other metabolic, etc., may have some implications in different types of metabolism. The uric acid is one of them. In summary, I do think that probably there is some impact in the uric acid production, but we are not sure absolutely how is the magnitude of that.
Thank you, Prof. Martinez. There was another question by the same colleague. I think his question was on proteinuria. How much reduction does the SGLT2 reduce proteinuria with time? I wonder whether Prof. Bernard Cheung can address the question. Prof. Cheung?
Oh, thank you very much. I think trials as well as meta-analyses have shown that there is a substantial reduction in albuminuria. I think a lot of trial data is expressed as odds ratios of reductions, but I mean, as we know that the SGLT2 inhibitors are now increasingly become a standard therapy for patients with reduced GFR. Although technically, if you look at the package inserts, I mean, there's a lot of caution about not using SGLT2 inhibitors in patients with reduced eGFR. But I think this is an instance where the regulatory bodies are behind the clinical evidence, and nephrologists are very excited about this. Yes, Felipe.
Absolutely.
I completely agree. I completely agree, and I think that the improvement of proteinuria is the reflect of the improvement of renal function. And what Bernard said, there is a consensus coming in 2 more weeks between cardiologists and nephrologists that has participated in the Dapagliflozin trials, heart failure and CKD, to trying to make a conclusion about what he said. These are a group of drugs that protect kidney function, and therefore proteinuria and all other parameters may also improve. I think there is enough evidence to say that.
Thank you, Felipe. I think Dr. Ricky has also written a comment in there on the improvement of microalbuminuria. Thank you, Ricky. I didn't see your comment until now. Sorry about that. I think the key thing that we want to point out to the audience out there is also that the labeled doses for SGLT2s to be used in heart failure is not the same as that used for diabetes. So be very careful about looking up the doses when you're using them, particularly for people who are not diabetic. And also because the various SGLT2 inhibitors, only empagliflozin and dapagliflozin has been somewhat studied in heart failure patients, but not canagliflozin. So be careful about how you're using them as well in the various populations. And also for the creatinine clearance and with respect to the renal function, I think that's something that we also need to be keeping an eye on, because I think empagliflozin, remember, was the one with the lowest cutoff. And I think for DAPA, there was some recent evidence with respect to dialysis patients as well. So I think they're pushing the labeling for DAPA further. Okay, before I try to dominate all that time, there's some other questions that's come up. However, I think we should go through the cases. What do you think, Claire?
Yeah, I think we can start on the cases, and hopefully we can use the cases to answer your questions as well. Yeah,
that's great.
So maybe you can get the organizers to flash the cases. Okay, so today we will be going through 2 cases, so we can see how we can translate the evidence of Prof Martinez into actual clinical practice. So for the first case, we have a 45-year-old gentleman, Mr. R, who was recently admitted for acute.
Sorry, Claire. I think we're having echo for your device. We're getting some echo.
The echo is from the organizer to switch off the volume.
Okay.
Okay, testing. Yeah, so sorry for that technical glitch. So I'll go through the cases proper now. So the first case will be a 45-year-old gentleman. We'll just name him Mr. R. He was recently admitted for acute decompensated heart failure 3 months ago. The latest echo report showed EF of 20%, so a HFrEF patient. In the most recent clinic visit, he was actually started on Dapagliflozin for his heart failure. Doesn't have any background of diabetes. The last A1C was 5.3%. Some background history, he has an evolved anterior MI in 2018, has single vessel disease with osteo LAD 100% occlusion, but it was for medical therapy because of the non-viable LAD. Okay, the next slide. So this time he came back to the clinic complaining of dehydration as well as giddiness after taking his medicine. He reports a blood pressure at home of around 98/73. And on the left-hand side, you can also see the trend of his eGFR ever since Dapagliflozin was started. So on initiation, eGFR was about 34, and after about 4 weeks, it dropped to 29. Other medications that he's on, aspirin, statin, and Trastol, he has reached maximum dose of 200 mg BD, Spiral, Biso, as well as the recently started Dapagliflozin. So for this case, I would say he has already been on he has been started on most of the goodies and the optimal therapy for heart failure. Okay, next slide. So building on this case, perfect, I'll direct my first question to Dr. Ricky. So as we can tell from the trials that actually initially in terms of the renal function, there's some initial worsening of the renal function after starting SGLT2. So I mean, in my practice, what they usually do, they will start the SGLT2 and then they will probably see a pharmacist maybe 2 to 4 weeks to check on the renal function. So in your practice, how much of this worsening of the initial renal function would you actually tolerate before you decide that, oh, okay, this patient cannot tolerate SGLT2?
Thank you, Claire, for that question. I do believe this is a very relevant question for all of us because we do see that sometimes the eGFR vis-a-vis the creatinine tends to worsen transiently sometimes in some patients. But in our clinical practice, not more than around 25% of our patients experience such a transient drop in this kidney function. But I think what's important here is that we recognize this phenomenon in the treatment of patients with heart failure using the SGLT2 inhibitors and not to just get a phase and stop the drug unnecessarily. Perhaps we could probably back off on some of the loop diuretics if ever the patients are on them. And given this patient's case, sometimes we tend to look at spironolactone as one of the drugs that we might want to back off on. In the titratable drugs, such as the ARNI, in some cases, we tend to back off also on 200 milligrams to 100 milligrams twice a day.
Okay, thanks, Dr. Ricky. I think this also builds on my next question, which you were kind of already answered in your answer of whether we would lower the other doses of the other medication. So now with SGLT2 being a bit late to the party, I mean the ARNIs and the beta blockers being already around, sometimes they're already on maximum doses and we have already pushed until they're at their maximum tolerable blood pressure. So I mean, in that case, would you kind of lower the other drugs, the doses in order to sneak in the SGLT2 just for the blood pressure?
Yes, I think that's quite realistic nowadays because we do believe that patients should not be forced titrated on their medicines. We know that a lot of problems run in for patients when they're forced titrated, and even the clinical trials allow tolerability titrations for medicines. And in real world practice, we of course have to prioritize how our patients tend to tolerate the medicine. So SGLT2 inhibitors, if they are not getting UTI or any problems such as this, then we tend to continue them. Being once a day, they're pretty good, I would say. So we would probably tend to prioritize titrating those, such as the ARNIs, just transiently, and then probably after around a couple of weeks, it ask them to come back and then reevaluate.
Okay, thank you, Dr. Ricky, for that invaluable insight. So building on that, I think you mentioned that sometimes we take out the loop diuretics in order to make room for the SGLT2. I think one of our audience also have a question of whether SGLT2 can be used during fluid overload for HFrEF since it has diuretic properties. Perhaps I can direct this question to Prof Bernard to take this question.
Oh, thank you very much. Well, I think loop diuretic would work much faster than SGLT2 inhibitors. I think in the acute treatment, if you want, quick results, you really, we can't get away from loop diuretics. However, I think in sort of more chronic treatment, as the SGLT2, the availability of SGLT2 inhibitors is actually very exciting because, as Felipe has explained before, it is a diuretic, but it works differently from the loop diuretics. You have less hypovolemia and certainly no electrolyte disturbances such as hypokalemia. So I think for long-term treatment, and of course loop diuretics have never been shown to reduce cardiovascular events or prevent mortality. And so I think, in the long run, we have to consider starting our patients on SGLT2 inhibitor, and such as dapagliflozin. However, in the short run, we still can't get away with from loop diuretics yet.
Okay, thank Prof Bernard. I think
Felipe has a comment.
Yes, first of all, I agree with the previous comments from Ricky and Bernard, but I have two additional questions. The first one is, I was really surprised with the level of LDL because I was thinking that a man who has this severe coronary disease before he's 40 years old should be some investigation about the potential familial hypercholesterolemia in this patient. And the second comment is he has a severe coronary artery disease. He has a heart remodeling with dilatation of left ventricle and a thrombus inside the ventricle. For some guidelines, it is recommended to put the patient in anticoagulants and not only in antiaggregants. What is your comments? What are the comments of Bernard, Ricky, Doreen about this?
I think Dr. Ricky has some comments to add in about Prof Martinez.
Professor Felipe, you're very astute on that one. I was also a little puzzled, but I do believe sometimes these patients with heart attacks, like in the Philippines, not all of them have monstrous levels of elevated LDL. I was thinking if this patient might be enrolled in the canakinumab studies wherein the inflammation level is pretty much higher than we expected, or their non-HDLs are probably higher than we expected. I don't know. Maybe their ApoBs are elevated compared to what we actually know below the surface. So yes, this does happen in clinical practice, but the professor is correct. Because more often than not, we see patients with actually elevated LDL. But in the Philippines, in our experience, not all patients who have heart attacks do get elevated LDL. But this patient who's 45 years old, I think probably genetically is predisposed to premature CAD. I would begin to wonder that beyond the LDL, there's something else happening to this patient.
May I address the issue about the thrombus? I think Felipe posed a question about the LV thrombus. Was it the mural thrombus that the patient presented with? Yes, commonly we would have used warfarin in Singapore. The DOACs are not quite studied in this population, and so this patient should preferably be on warfarin if there was LV thrombus that was found. I think the other comment that I wanted to make was about the use of loop diuretics versus SGLT2 inhibitors. I think it's critically important to recognize that when a person is in exacerbation of heart failure, there are some shifts in how the kidney handles fluids. So I think it's critically important to think about the clinical pharmacokinetics and pharmacology of loop diuretics in that setting rather than SGLT2 inhibitors, because the mechanisms of actions are different. And definitely someone who is in acute decompensated heart failure or someone who is in fluid overload, we would definitely want to give loop diuretics as well. Back to you, Claire.
Okay, thank you all for the very valuable insight. I think I'll move on to my next question about this case on how we can actually manage dehydration or hypotension after starting SGLT2. I think one of our audience also had a question on how we can balance the risk of dehydration and fluid overload, especially with multiple drugs with diuretic effect. So now with SGLT2, as I have Ani having a malnaturistic effect, how do you, maybe I'll direct this question to Prof Martinez, how can we possibly manage this hypotension or dehydration so that we can continue on this pharmacotherapy?
You're asking to me that question?
Yes, to you, Prof Martinez.
I would say that when you see the results of the adverse events in the 2 or 3 major trials with SGLT2 inhibitors, the hydration or hypotension are not important, and this is something that must be taken for the clinical practice. And I don't remember exactly, but I don't think we have in DAPA-HF and in DAPA-CKD no more than 0.1 hypotensions or dehydration that were clinically important, significant. Therefore, probably the take-home message is that even after starting one or the other SGLT2 inhibitor, the management of these 2 problems should be the same that in the usual care of this type of patient. Not any special or extraordinary strategy to manage this kind of patient.
Okay, thank you, Prof Martinez. Building on that, actually like to ask your opinion on what you think of starting lower dose SGLT2, such as DAPA 5 mg or EMPA 5 mg in patients with very low blood pressure or have higher risk of dehydration, and possibly maybe up titrating it in about 2 to 4 weeks' time. Any evidence for such a practice?
No, I think there's no evidence for that. The 10 milligrams dose has been used as the unique indication in all trials, and when you see the expert consensus and even the ESC guidelines, they recommend 10 milligrams of both DAPA and EMPA. So I think there is no enough evidence to answer if you can. It is recommended to a lower dose in those cases.
Okay. How about Dr. Ricky? Do you have any experience in your practice? Do you commonly see a DAPA 5 or EMPA 5 being started?
Well, fortunately, I would probably say fortunately, no. They seem to tolerate the 10 milligram dosing here locally, and we just basically watch them fairly closly on follow-up when we start these medicines, and we take orthostatic testing at the clinic. So far, when we do get orthostasis, we probably would have done what we discussed a while ago and see what medicines we can titrate and advise our patients accordingly.
I think that the earlier practices of using this half doses of the SGLT2 inhibitors could have resulted from the fact that they were relatively expensive. And also there wasn't much data on the use of SGLT2 inhibitors in renal impairment. So I think people were trying to use it as well in some patients that were renally impaired. And that's how the practice started. But I do agree that it's important to take note about the doses that's been studied, and there's no such thing as half doses, whether it be cost savings or anything else like that. Claire, I think there was a question from Franco on the fluid intake and how we should balance the risk of dehydration with fluid overload, especially when there are multiple drugs with diuretic effects for HFrEF. I wonder whether either Felipe or Bernard has got experience with that, or maybe Ricky as well. Like, did you get into trouble with patients with SGLT2 together with loop diuretics, and then with some maybe diuretic effects as well, mild ones with the RNAs?
Go ahead, Bernard.
Yep. Bernard?
Oh, right. Okay, thank you. Well, I think it's a very good question, and it's a very pertinent and relevant clinical question. My thoughts are, I think it depends on the type of patient, because nowadays, you know, there's a broader spectrum of patients being treated with SGLT2 inhibitors. Now, if they are diabetic, they would have a high glucose load in the urine, you know, polyuria and all that. And SGLT2 would, you know, increase the, you know, glycosuria. And so I can imagine that, you know, those diabetic patients with high levels of glucose may actually end up more dehydrated. Then, you know, at the other end of the spectrum, you have the non-diabetic patients on SGLT2, perhaps for renal protection. Then, you know, then they probably are very less likely to be dehydrated. So I think it depends on the patient. I think a lot of early experiences had been with diabetic patients. And I know that my endocrinology colleagues are super cautious about SGLT2 inhibitors, warning their patients that they could get dehydrated or even dizzy and faint. I suspect that we see less of that in the sort of non-diabetic patients, or diabetic patients are better controlled.
Yeah, and I think Claire will probably identify with me, because as pharmacists, when we see patients in clinic, we are really OCD about getting them to measure their body weights daily, right? So that's one of the first few things that we teach them to watch out for, those red flags of putting on weight and all that. So I think if the patients can self-monitor and they can tell when they are starting to get dehydrated, I think that's the more important thing, because as healthcare professionals, we can't always be watching over their shoulders. They have to learn to take care of themselves. Yeah, Claire,
Okay.
back to you.
Yeah, with that, I think in view of the time, we will move on to the next case. So the next case will be an 85 years old lady. We'll name her Mrs. J. So she has a history of non-ischemic cardiomyopathy and atrial fibrillation. The latest echo EF is 50%. Background of hypertension, hyperlipid, stroke, and CKD. So here we have a HFpEF patient in the setting of SGLT2. Next. So she was just discharged for decompensated heart failure last month. So when she comes to the clinic, she talks about hope of feeling better and avoiding another hospitalization at this age. Her blood pressure is about 150/80, heart rate at 70, A1C 5.5%, the EGFR of 40, likewise non-diabetic HFpEF patient. Her medications are rivaroxaban, bisoprolol, digoxin, as well as furosemide for her overload. Next. So just maybe I can direct this question to Prof Bernard. Looking at this patient's demographic, would you start in SGLT2 for this patient? And now with the trials on Emperor, Preserve, as well as upcoming trials on DAPA and HFpEF, I think this is one of the more exciting times for HFpEF patient. Any particular subgroup that you would not start SGLT2 in, since HFpEF is actually quite a heterogeneous condition?
Oh gosh, I think, you know, I think SGLT2 inhibitors are suitable for really most subgroups, as Felipe has shown earlier, regardless of, you know, whether they are young, old, you know, regardless of ejection fraction. And I noticed that the ejection fraction in this patient was 50, which was kind of borderline. But you know, you can almost regard this patient as a patient with preserved ejection fraction. And so I think SGLT2 inhibitor would be very high up on the list of treatments. Particularly, I noticed that her blood pressure is not very well controlled. The systolic was 150 something. And so I think, you know, we talked earlier about hypotension and all that. So I think in this patient, there's no danger of hypertension occurring yet. So I think we can add on, you know, treatment. So SGLT2 would be high on my list, but you can also add the blockers of the renin-angiotensin system, because her blood pressure is still high.
Felipe, do you have concerns about using SGLT2s in frail elderly? Because I think there could be some endocrinologists in our midst, and I think they typically like to use the DPP-4 inhibitors in the frail elderly, mainly because they think for diabetic patients, like frail and elderly, they tend to be safer in terms of the profile.
First of all, as Bernard said, I showed one sub-study that we published in Circulation, analyzing the different group of ages, and it was shown that this group of drugs are very safe in elderly patients. And even the benefit is more important than in younger patients. So you can use, I completely agree that this is a typical patient that we can use SGLT2 inhibitors since the beginning. Second, regarding spironolactone, since the renal function is not 100% the optimal level, and because she has 85 years old, I would monitor the potassium level before indicating spironolactone. And if we decide to indicate the drug, the monitoring of potassium plasma level should be very strict. Regarding another concept, and let me make some comment about the previous cases. Since I am the older one in this panel, I remember when we facing the change from digitalis to enalapril to ACE inhibitors. Most of the questions, the comments, and the doubts that you were saying about the endocrinologists using SGLT2 inhibitors or other groups of colleagues were exactly the same when they suggest the guidelines, and the major trials in that time showed that enalapril and captopril were superior to digitalis. Many of the colleagues were with some doubts about the use of this because those drugs were used in hypertension and could produce hypotension, in heart failure, etc., etc. Exactly the same that you are saying now. I think that the evidence in this case is very strong. These are very effective drugs, safe, can be used in elderly patients, and can be combined with many other groups of drugs. For this patient, I will use, without any doubt, SGLT2 inhibitors, 10 milligrams of EMPA or Dapagliflozin, and I'm not sure about the spironolactone.
Thank you, Felipe. I was just thinking in the recent labeling of the RNAs as well, that the HFpEF population with EF of less than 50, we might actually be considering the addition of an RNA here for this lady as well, right? So I wondered what Ricky thought about this. Like, if it was a patient that presented to you today, would you have chosen SGLT2 first or RNA first? How would you have treated this particular patient?
Well, first of all, I agree with our dear colleagues tonight that this drug is really suitable for this type of patient, knowing HFpEF and with an eGFR of 40. So I think very, very much strong in actually also preserving kidney function over time. And I think also suitable is also because it's once a day, easy to use. And as the professor had shown a while ago, there's been a 4-week recommendation to actually prioritize on top for because it's easily used, and the results, you don't need to wait for like a systematic trial over RNAs first and then everything else thereon. So it's very practical to give from the beginning. So what else, Doreen, would be the question for this?
So for this lady today, would you have chosen SGLT2 inhibitors or ARNI to be adding on for her.
Yeah. So I think personally I would choose the SGLT2 inhibitor from the beginning, and then I'd work myself up on the others as I go along. If my patient actually still remains symptomatic, then probably I could add an ARNI in the second or the third stage just to improve the symptomatology. Why is that? Because in the Paragon, the women actually tended to benefit more with the ARNI, and particularly in the MIF, mildly improved EF range in that tertile between 45 to less than 51%. So this might be appropriate or suitable for a patient, but probably I would start with the SGLT2 inhibitor.
Thank you, Ricky. That was very elegantly put. And yes, Ricky has very nicely pointed out that the subgroup analysis showed that the EF less than 57 actually, but was labeled as 50. And then females also benefited from the ARNI in this preserved EF population. I think they have also, I think amongst everyone, answered some of the questions that were here. I think Prof Koji also has added on to the fray by saying all first choice drugs should be added, including the ARNI and SGLT2. Let's cut off the digoxin. Yay, we've all an agreement here. There was also a comment by Jeremy who's asking about when the eGFR goes down 1 month later, should we stop spironolactone first or DAPA first? My vote would have been for spironolactone because I think the renal function will continue to progress. And for spironolactone for eGFR for 40, we don't have that much data for the later stage CKD patients. Whereas for the other agents that we know, even with the ARNIs today, there seems to be some data that suggests that the ARNIs also preserve renal function in terms of how the progression is as well. So goodbye spironolactone. It's going to be SGLT2s and the ARNIs in favor. Claire, would we have other questions that we want to deal with? Maybe the questions on infections and lower limb? Yeah.
Yeah, maybe we can take that question. So I think we have a very strong SGLT2 support group over here. Everyone's got like for SGLT2. I think this was also quite interestingly something that I encountered today. In the case that patient has a UTI, do we need to withhold them in the period where they actually have an active UTI, or in this case, the person is asking active lower limb infection or UTI, would you all selectively withhold it for that duration? Maybe I can direct this question to Prof Martinez.
I didn't understand what is UTI.
Urinary infection. Yan Pei, you used the unapproved abbreviation.
Yeah. We use the same acronym here, but I couldn't understand. Probably it was a connection problem. First of all previous trials have demonstrated that the incidence of urinary or genital urinary infections are the most common secondary adverse event with this type of drugs. But this is true for the diabetic population. When you compare diabetics versus non-diabetic patients, the difference is with a significant P, because it's much lower in non-diabetic patients. And now, what we do, I think that was the question, Claire. If we have a patient that we have prescribed an SGLT2 inhibitor and the patient has a urinary infection, I think that you have to stop the SGLT2 inhibitor to treat infection, and if it disappears in a normal timelines, you can restart the SGLT2 inhibitor. But it is true that is the most common adverse event, but I repeat, in non-diabetic patients, the rate is very low. That was the question? That was the question?
Yeah, that was the question. I think you answered the question. Yeah, so seeing that it's almost close to 7, we will take the last 2 questions and then perhaps we'll round off this discussion. Firstly, we have the question of given the many benefits of SGLT2, as we can see from our discussion that everyone is really in support, especially with the latest evidence in HFpEF. What are some of the notable adverse effects in the long run that we need to be careful of? Seeing that the trials are actually not really done, and we, like Felipe said, we don't really have much experience with it, using it long run, but like what happened with enalapril, now we are using it for everyone with HFrEF. What are some of the notable adverse effects that you all think that might be of caution in the long run? Prof Bernard can take this question.
Oh, right. Okay. Well, as you pointed out, we actually don't have very long-term data. I mean, such as, for instance, what about carcinogenicity? I mean, this class has not been long enough, but there's no, but there's no signal pointing to that. And I said before, infections are more common. Perhaps not so much cystitis or pyelonephritis. It's very often it is outside the urinary tract, such as in the skin and so on. So that could be quite common, especially in diabetic patients. And another beauty of the drug, it occurred to me just now, is that it's unlike blood pressure other blood pressure drugs. You can actually withhold it for a few days, and I don't think any harm would go. I mean, you will have rebound hypertension or rebound hypoglycemia. So in that sense, it's a very safe drug. Having said that, we do, out of caution, suggest to patients when they are, dehydrated, when they have diarrhea and all that, to withhold it whilst they have the acute episode of dehydration for whatever reason. So I think it's quite a safe drug to use, with more experience. I think it's going to be very safe. But again, there are no really long-term data on it.
I think it's really for us to see in the next few years how these drugs evolve and how it actually is being used in clinical practice. I do agree about the withholding. I think in some practices, if patients going for ARB or they need to fast, they do advise them to hold off for at least 1 to 2 days, just to ensure that period of time. Because like you said, there's not much real adverse effect of withholding, like their high blood pressure won't go like haywire or anything. Yeah. So to round off this session, perfect, we can take this question by Prof Koji. So I think he brought up the anti-inflammatory mechanism being a very interesting hypothesis, and he would like to ask if there are any information or inflammatory markers such as CRP in heart failure clinical trial. Maybe I can direct this question to Prof Martinez. I think he would have some thoughts on this.
Koji makes always excellent questions, and this is a key one. Really, I do think that inflammation will become an axial important pathogenic mechanism in most of cardiovascular diseases, not only heart failure, atherosclerosis, hypertension, etc. And you know that there are in the pipelines some anti-inflammatory drugs planning to be investigated in pure cardiometabolic diseases. So I am absolutely convinced that inflammation will be one of the main drivers of our investigations in cardiovascular disorders or cardiometabolic disorders in the next 5 or 10 years. I don't know if Koji is satisfied with this answer, but I really think it is very important.
Okay, thanks, Prof Martinez, for giving us an insight into some other mechanisms and hypotheses. Maybe just one last question from me. I think just now when I was asking about how this patient, whether this patient is suitable to start SGLT2, and Prof Bernard did highlight that her EF was 50%. So I mean, it is slightly reduced from the normal. We do see some blunting of effect when the EF goes up in the clinical trials, especially in the Emperor pool. I think they did pull together the whole spectrum of EF, and did see that the benefits actually blunted at around more than 60%. So with this actually, maybe I will just direct this last question to Dr. Ricky. What do you feel about using SGLT2 in patients with EF more than 60%? Would you still start them as readily as you would have started this lady over here?
Yeah, it's to our understanding perhaps that the supernormal or the higher spectrum of HFpEF patients are probably the more unknown type of patients who might benefit from these drugs. But as a group, we tend to understand that HFpEF patients will benefit from SGLT2 inhibitors as a whole. So probably the future will help us understand whether these patients above the EF of 60% will actually be a special population that might need more specific treatment for that matter.
Okay.
Thank you. I think some of the arguments about the EF more than 60% is that maybe because heart failure is a clinical syndrome, they might have confused it with other indications, like maybe some confounding lung diseases that actually see that maybe these pharmacotherapy is not as beneficial in those EF 60%. But I guess we will see in the future how this will actually play out.
All right, so I think we had a very good time. I think we just want to remind everyone that even though the SGLT2 inhibitors, as I've joked earlier, we could be drinking it and not drinking water daily, we do have to remember that there's that population that are at risk as well, the high stress population, people who are going for maybe a prolonged surgery or they're going to be in a state of starvation. There are people who believe in sick day rules like that. Some of the highly critically ill patients, we might want to hold them off while they're in the hospital. So don't forget the population as well with respect to the long-term safety. There, I think some protocols and some practices that for people who are going for major surgeries, they might actually be holding off the SGLT2s for a while. And after all, we're going to be hypocounting our patients and doing the sliding scales with insulins and all that. So we don't really need the SGLT2 in the acute care setting. So please watch out for those people. Without further ado, I'd like to thank the great panel today. I think it was a wonderful discussion. Everyone was sharing their knowledge, and I hope that the attendees also have attended, who have learned as much as I have. I really enjoyed the panel who was so freely sharing their evidence. I think I'm this much smarter today. So thank you very much, everyone. So we hope that you join us in the February session. I will be talking about more A to Z topics. All right. Good evening, everyone. Goodbye.
Bye. Thank you.
Good night.
Do you guys want to take a picture? Oh, Claire's gone.
Oh.
Whoops. Oh, Claire's back. Oh, but Felipe is gone. Dang.
Oh, gosh. No, congratulations, Doreen.